Hi, everybody. This podcast is an introduction into the oxygenation chapter. That chapter is chapter 41 in your Perry and Potter book, and it starts on page 871. This podcast will take you through about the first 15 slides, and I would encourage you to listen to this before lecture as it's kind of the introduction. A lot of this material, the reason I'm taping it is because we don't have enough time in class, but also a lot of the material that I'm covering should be review. It was most likely covered in anatomy, physiology, and I know most of it was probably covered in health assessment also. So let's get started. If you turn to the first slide, it's labeled respiratory physiology. And it's really where we think about the primary function of our lungs is really to transfer that oxygen, bringing it in from the atmosphere into the alveoli within our lungs, and then we exchange it with the carbon dioxide that we can release out then as a waste product. A body's ability to take in oxygen and to breathe off that carbon dioxide can be thrown off by a lot of disease processes and conditions that you'll learn about in the next couple of years. So you'll take those along with your fluid and electrolytes and really build that understanding of how our breathing can be affected by a lot of different disease processes. We also want to think about the diaphragm because it really helps us take in and release those breaths, if you want to think it as kind of that major part that helps us with our breathing. So the diaphragm, there's external intercostal muscles that help contract. And so when it contracts, the diaphragm increases in size, and we take in as it contracts, we take in, actually as the diaphragm shrinks, we take in that extra air and we fill that air, that inspiration, we fill that air with the air from the atmosphere. So we fill in our lungs. As that diaphragm then relaxes, the contraction of the internal intercostal muscles allow the air, then it kind of pushes in and allows the air to escape from the lungs. If you turn over to the next slide, it talks about the steps in oxygenation. There's 3 main steps that we'll hit on today. And they're on the following slides. So the first one is ventilation. Ventilation is essentially the process of moving gas in and out of the lungs. So we breathe in gas, and then we also exhale the carbon dioxide out of the lungs. So that's just essentially ventilation. We're breathing in and out. Perfusion then is the ability of the cardiovascular system to pump oxygenated blood to all the different tissues in our body and then return that deoxygenated blood after it's dumped off all the oxygenation, return that back up to the lungs to get reoxygenated. The third step in oxygenation that we're going to talk about is diffusion. And diffusion is really the exchange of those respiratory gases that happen in the alveoli and the capillaries of the lungs. And we'll talk about that as we go on. If you flip to the next slide, there is some respiratory terminology listed there. So the first one really talks about the work of breathing. And if we think about the work of breathing, it's really the amount of energy that we use to breathe. So it really depends on a couple of things. It depends on the rate and the depth of the breath. So the faster we breathe, the harder of the work it is to breathe. If you tried to breathe fast for a longer period of time. And also the depth of the breath. So when I think of the depth, I think of like a pool. Do I have the shallow end or the shallow breathing where I'm taking little breaths but not really taking in that much air? Or am I in the deep end of the pool where I'm taking and inhaling large amount of breath and then exhaling large amount of breath? So for instance, when you're at the doctor, they might say, take a deep breath. Well, and then that's what you'll follow up with. So we really want to think about how easy is it for the lungs to expand, and there's a couple of things that we can think about. For example, one of them is a disease process called COPD. It's a very familiar one. You might have heard of it, otherwise known as chronic obstructive pulmonary disease. And when somebody is diagnosed with chronic obstructive pulmonary disease, it really becomes harder for them to breathe because they lose that elasticity or that ability for the lungs to expand and contract, and it makes it harder for them to breathe in and out. So that's just kind of an example when we think of somebody having that trouble breathing or how much work it is to essentially breathe. The second there, it talks a little bit about inspiration and expiration. So inspiration is really just that active process of bringing in, we inspire or we bring in that oxygen into our lungs. What makes our body want to do that? Well, there's a neural pathway that's regulated up in our respiratory center of our brain. And so that pathway in our brain, it has what's called chemoreceptors. And these receptors are located in the heart, and they're also located in the brain. And they sense that oxygenated or that deoxygenated, they sense that blood that's circulating throughout our body. Once that blood gets a higher level of carbon dioxide than the oxygen, then it will start to sense, and it essentially stimulates that brain to say, well, we are sensing a higher amount of carbon dioxide than we should in levels. And so what it will tell the brain to do is it will stimulate, the chemoreceptors will stimulate our body to take deeper breaths and more rapid breaths so that we can get that excess carbon dioxide off. So when we breathe, it decreases those carbon dioxide levels. Expiration is the other hand of when we're expiring, we're actually breathing off. So inspiration is breathing in. Expiration is then that passive process where we breathe out or we breathe off that carbon dioxide. There are some other terms listed on that slide. Surfactant is a chemical produced in the lungs. So essentially it's kind of, if you want to think it of as grease or the WD-40 that keeps those alveoli from collapsing. So it's in each alveoli, and that surfactant is kind of if you want to think of it as like a lube, where it helps to be able for those alveoli to expand and contract depending on where the air, whether the air is coming in or going out. Sometimes in the hospital or clinic setting, you might hear of a term called atelectasis. And atelectasis is essentially when those alveoli are collapsing, and it prevents us from having that normal exchange of oxygen and carbon dioxide in the lungs. Because it collapses, it's unable to do that. As you move on to the next slide, it also has some terms there. So you still see inspiration and expiration at the top, but it also goes into pulmonary circulation. And we'll get into that here in a little bit, but when we really think about pulmonary, we want to think about the lungs. So pulmonary is moving the blood to and from the alveoli capillary membranes for gas exchange. So when the blood is circulating through the lungs, it brings it to the alveoli so the blood can take on more oxygen and then release off that carbon dioxide. We'll talk about the blood flow of that here in a minute. There are some terms then on the bottom of that list on that slide that you might want to become familiar with. It talks about lung volumes. The first one listed there is tidal or tidal volume, you might see it. Tidal volume is essentially an amount that we can measure, and it's essentially the amount of air exhaled followed by a normal inspiration. So you take in your normal breath of air, and the tidal volume is what we normally exhale on a normal inspiration, and then what we exhale on the expiration is our tidal volume. They also talk about a residual volume. A residual volume then is, if you think about the word residual, is the air left in the alveoli after full expiration. So do we use it all? We don't necessarily get it all out. How much is left over, or is that residual? And then the last one is FVC, or forced vital capacity, that I want to hit on. Forced vital capacity is really the maximum amount of air that can be removed from the lungs during forced expiration. So essentially that's where you're forcing it or working very hard to get every amount of air out of there. As you flip to the next slide, it talks a little bit about the respiratory gas exchange. And we mentioned diffusion a little bit earlier. And diffusion is the process of exchange of respiratory gases in the alveoli. So you'll see all the little circles there with the alveoli on that picture and the capillaries of the body tissues. And so what happens is those respiratory gases diffuse with each other. So we have the oxygen coming in from the atmosphere being inhaled, going down into the alveoli, and then we bring the blood in and we have the exchange of the unoxygenated blood. We grab onto the oxygen and bring out the waste product to be expired of the carbon dioxide. Sometimes we get patients that have an increased thickness of those membranes, and that really works to decrease the diffusion that happens because of that thickness of the membrane. It takes longer for those gases to transfer across the membrane. So patients, you might have heard maybe patients with pulmonary edema, infiltrates, pulmonary gases, decreased delivery of oxygen to the tissues. Sometimes these might result in chronic diseases such as things like emphysema, a pneumothorax, different things like that decrease the amount or decrease the exchange or the amount of the exchange because of that impaired exchange amount or that impaired diffusion to take place. When we think of the oxygen transport system, we can really think of the two main things that we're going to talk about today and in this lecture. So we think about the pulmonary or the lungs, and then we can also think about the cardiovascular system because it takes the lungs and the heart working together to oxygenate and filter that blood throughout the body. There's three things that really influence the body's ability to, the ability of the blood to carry oxygen. So the three things, the first one is the amount of dissolved oxygen in the plasma. So how much oxygen is going into the blood. The second one is the amount of hemoglobin, because the hemoglobin is our transport vehicle. So how much of the oxygen and how much of the hemoglobin are there? And then thirdly then is the tendency of the hemoglobin to bind with oxygen. So can the oxygen essentially get in the car to be transported, or doesn't it bind very well to the oxygen? So those are three things that we can think about for that influence the capacity of the blood to carry oxygen throughout our body. The first one is the amount of dissolved oxygen in the plasma or in the blood. The second one is the amount of hemoglobin. And the third one is the amount of hemoglobin that will bind with the oxygen. Hemoglobin is the carrier for oxygen. So we talked about it being like the transport vehicle, if you think of a car or whatever. It's the carrier for oxygen, but also carbon dioxide. So it transports most of the oxygen, probably about 97% of it. And once the oxygenation has been left off, the nutrients have been let go at the tissues, it binds then with that carbon dioxide, then will go on board with the hemoglobin, and it will bring then back up for that blood to get reoxygenated again. And then the lungs will exhale that carbonated carbon dioxide from the blood. If you flip to the next slide, it talks a little bit about the regulation of respiration. And there's two kind of regulators, the neural regulation and the chemical regulation. And the regulation of our respiratory system is necessary in order to ensure that sufficient amount of oxygen intake and carbon dioxide elimination meets the demands of the body. So things like exercising, it has an increased demand. If someone has an infection or is pregnant, those things have to adapt. Our body needs to be adapted to control that amount that we need. So the first one is neural regulation. And really when we think about neural, we think about the central nervous system and how that controls the rate of our respirations. It also controls the depth of our respirations and the rhythm. So do I have unlabored breathing or labored breathing? My rhythm might be very regular or might be irregular. So the cerebral cortex in our brain controls that respiration, and it delivers impulses to the neurons by way of the spinal cord to allow us then to know whether to take, obviously, to take that breath, hopefully. There are also chemical regulators that help to maintain the rate and the depth of our respirations based on appropriate or inappropriate changes in the carbon dioxide, the oxygen, the hydrogen concentrations, or the pH of the blood. So these changes in the chemical content of the oxygen, carbon dioxide, and the hydrogen, or our pH level, stimulate those chemoreceptors, and they're found in the brain, the aorta, and the carotid part of the body, which simulate those to adjust depending on what they're sensing for the amounts of those chemicals, the rate and depth of the ventilation to maintain those normal blood gas levels. And sometimes you'll hear about ABGs, arterial blood gas. That's what those chemoreceptors are regulating. If you flip to the next slide, it talks a little bit about the cardiovascular physiology. And the cardiac system delivers oxygen and nutrients and other substances to the tissues and really works to remove also the waste products, like we talk about with the carbon dioxide, by way of that blood flowing through our body systems, such as the respiratory system, the digestive system, and the renal system. So the primary functions of the heart is to deliver the deoxygenated blood. We need to get the deoxygenated blood to the tissues so that they can be reoxygenated, and then that oxygen then can go throughout the body to deliver oxygen and nutrients to the tissues. If you click over to the next slide, it talks about continuing the cardiovascular physiology, and you'll see there's kind of a blood flow chart there. And again, this was, I know, covered earlier in the year in your assessment class, but just to review, there's 4 cardiac chambers. So there's 2 atrias and 2 ventricles. On the right ventricle pumps the deoxygenated blood through the pulmonary circulation. And then we have the left ventricle then that pumps the oxygenated bloods through the systemic circulation. So as it goes through the whole circulatory system, it exchanges the respiratory gases, nutrients, waste products between the blood and the tissues. If you click to the next slide then, I have it listed 1 through 14 is the circulation of the blood flow throughout the heart and the lungs. It is very, 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 very important that you know this blood flow, because this will show up on a numerous amount of tests, whether it shows up just like this, the circulation, or it helps you decide when you get into next year about which disorder you might have based on what's going wrong and where it's going wrong within that blood flow of the heart and the lungs. So it's really important. So what I did here is I started it with the superior and inferior vena cava, where that deoxygenated blood comes into the right atrium, and then it goes down through the tricuspid valve into the right ventricle. Then it goes into the pulmonic valve to the pulmonic arteries, which goes into the lungs. And so when that blood goes into the lungs, it's going to that alveoli. It's exchanging the carbon dioxide or the waste product for the oxygen that we're inhaling in from the atmosphere. Once it gets reoxygenated, then it goes back through the pulmonic vein to the left atrium, and then through the mitral or the bicuspid valve down to the left ventricle, out through the aortic valve to the aorta, and then out through the rest of the body. And then that whole process then can start again. So it's really important you need to know that. As you go through to the next slide there, that pumping action of the heart, that myocardial pump, is really essential for that oxygen delivery to the tissues. The ventricles, when they fill with that blood during diastole and empty during systole, those myocardial fibers, if you think of the fibers of the heart or that muscle, so the heart is a muscle, and as it contracts, that muscle is allowed to stretch and contract. So it stretches out during filling and then contracts when it actually pumps and sends the blood out. So when we in order to have adequate blood flow to the pulmonary, so to the lungs to get reoxygenated, but also to the systemic circulation, it really has to be sufficient in order to pump all that where it needs to go. So blood flow within that system should be unidirectional, meaning that it only goes one way. So those 4 heart valves that I mentioned earlier help to make sure that the blood only moves forward in the one direction. So in the S1 and the S2 are when those valves open and close. As you flip to the next slide, it talks a little bit about blood flow regulation. Again, just some terms to become familiar with. Normal cardiac output. So our cardiac output is the amount of blood ejected from the left ventricle each minute. So we're only going by a minute here. So the left ventricle is bringing it out through the aorta to the rest of the body. So this is how much blood the heart is pushing out to the rest of the body per minute. And in a normal resting healthy adult, that should be about 4 to 6 liters per minute, which is quite a bit. The volume of blood ejected by the ventricles during systole is referred to as the stroke volume. So that's a little bit different, where it's during how much is ejected from the left ventricle with each contraction. So cardiac output is per minute. Stroke volume is each contraction. So when we think about cardiac output as a whole, if we take stroke volume, so with each contraction times the heart rate, because that's how many times it's contracting in a minute, that's where we can get our cardiac output. So cardiac output equals stroke volume times the heart rate. Things like hemorrhage, so when a person bleeds out or loses an extensive amount of blood, or becomes dehydrated, meaning that they're low on fluids, it can cause a decrease in that circulating blood volume, and it would then eventually decrease that stroke volume. If you turn to the slide after that, it looks a little bit at the conduction system. So normal sinus rhythm starts in that SA node and follows through a normal sequence in that conduction system. And a lot of times, so you'll have the SA node and then the AV node. So it runs down, so it starts in the SA node. And the SA node is considered sometimes what we call the pacemaker of the heart. And it kind of sits right in the right atrium by the superior vena cava. Then it goes down into the AV node, the atrioventricular node, down into the bundle branches, the bundle of His, the right and the left bundle branches, and then the Purkinje fibers, which then delivers that then to that electrical current, then to the heart, the ventricular part of that heart muscle. So the conduction system, if you flip to the next slide, really generates the impulses needed with that electrical kind of chain of action for that normal heartbeat. So to have that regular S1 and S2 heartbeat. The autonomic nervous system also influences the rate of that impulse generation and the speed of how fast it's going. And so the autonomic nervous system is really part of that nervous system that controls the involuntary actions. Then we can go into the sympathetic nervous system that really also works to increase the rate of the impulse. Also, the parasympathetic nervous system, so they all play a specific role. Sometimes you may have seen, as you flip to the next slide, you'll see what it's labeled as a normal electrocardiogram waveform. So an electrocardiogram, sometimes known as an ECG or an EKG, reflects that electrical activity of that conduction system in your heart. So the EKG or the ECG really monitors that regularity and the path of that electrical impulse through the conduction system. And so the normal sequence of that is referred to as normal sinus rhythm. You can see on that slide what that looks like. You will, as you advance into your nursing junior and senior level, you will learn more about those and more about the abnormalities. We are not going to get into that at this time. That's actually going to be the end of what we're going to do as a review. We will pick up the slides, the rest of it in class, and we will go from there. Hope you guys have a great night, and thanks for listening.